Welcome to Academy of Ultrasound's echocardiography course. Tonight, my name is John Sheldon. I'll be your instructor this evening, and tonight we're going to talk about Echo232 week 3, which is dealing with infective endocarditis. We'll be using the Feigenbaum book tonight, chapter 13. You can follow along on your screen, and we'll be looking at all the appropriate figures and discussing each one of your lecture notes. On the right-hand side, you'll see your lecture notes. On the left-hand side is a copy of the book. Please feel free to follow along. Let's dive right in. So infective endocarditis remains a challenging and often fatal condition. It's a reason for being a challenging and fatal condition is due to the difficulty of establishing an accurate diagnosis, particularly early in the course of the disease. The role that echo plays is a demonstration of a valvular vegetation. So when you're doing a patient in the hospital, for example, and you get a patient that has, let's say, a fever as the cause, they're looking for possible endocarditis, and they're looking for a vegetation. Clinical perspective, infective endocarditis is defined as a localized infection anywhere on the endocardium. Vast majority of vegetations, however, occur on the valve leaflets themselves. The infection may develop on an implanted or prosthetic material like prosthetic valves, conduits, pacing electrodes, and catheters. Process of developing endocarditis can be a bacteremia or fungemia. The initiating event usually requires a high-velocity jet due to a congenital anomaly such as a ventricular septal defect, a regurgitant or leaky valve, or a prosthetic valve. Jet interferes with the protective endothelial surface, allowing the blood-borne pathogens to adhere and coalesce. As the infection organizes, masses of microorganisms attract platelets, fibrin, and become adherent to the endothelial surface to form the vegetation. Vegetations will grow in size. The ability to detect the vegetation is the focal point of diagnosis. So echocardiographic characteristics of a vegetation. Your essential first step in the echo evaluation is to search for evidence of an acute ongoing infection. Most common and direct evidence of infective endocarditis is the vegetation. Vegetations are typically irregularly shaped, highly mobile masses attached to the free edge of a valve leaflet, such as in Table 13-3. Let's go look at Table 13-3. Positive features for a vegetation. A low reflectance attached to a valve on the upstream side. Irregular shape amorphous. Mobile oscillating. Associated tissue changes and valvular regurgitation. Vegetations tend to develop on the upstream side of the valve, such as in Figure 13-1. Upstream side of the valve. You see the LV vegetation right here, indicated by the arrows. You have vegetation on this side where the flow goes through. You have the vegetation on this side where the flow goes through. Usually have motion that is independent of the valve itself. Motion is frequently described as oscillating or fluttering. Absence of mobility argues against the diagnosis. Shape and size of vegetations are quite variable, and fungal vegetations tend to be larger than those caused by bacterial infections. Those involving the tricuspid valve tend to be larger compared with vegetations that affect the aortic or mitral valve. They may also attach to chordae, chamber walls, or in any foreign body, such as a pacemaker lead, a catheter, or prosthetic valve sewing ring, such as in 13-2. Let's go look at 13-2. This is a large mass attached to the pacemaker lead. Large mass, pacemaker lead. The mass is typically homogeneous with echogenicity similar to that of the myocardium. You'll notice that the mass itself looks very, very similar to the heart walls. Can occasionally be cystic or appear more dense and calcified. Some degree of regurgitation is associated with most cases of acute endocarditis. In figure 13-3, mitral valve vegetation. 13-4, aortic valve vegetation and associated colors. Less often, a large vegetation will obstruct the valve orifice, leading to a functional form of valvular stenosis, and that's in 13-7. So it's actually going to obstruct the valve orifice itself, leading to your spectral Doppler, which almost has the appearance of mitral stenosis. It should be emphasized that no single characteristics on the echo that will conclusively identify a mass or vegetation. Ability to detect a vegetation depends on several factors, including vegetation size, location, and presence of underlying heart disease, image quality, and instrument settings. All available echo windows should be used, and the rule of thumb is you must show the item or the specific piece in question in more than one window in two different views. In most cases, a vegetation should be at least 3 to 6 millimeters, must be at least 3 to 6 millimeters to be reliably seen. This is the advantage of a TEE or a transesophageal echo. It can see them at much smaller. Vegetations must be differentiated from other echo-producing abnormalities such as myxomatous processes, degenerative changes, including Lamble's excrescences, and calcification, tumors, thrombi, and imaging artifact. A Lamble excrescence, if you look it up on Google, it has actually a little tiny fibrous projection that comes off the back of the aortic valve that you'll see sometimes can be mistaken for a vegetation, but it's not a vegetation. It's actually a normal finding. Look up Lamble excrescence on Google and you'll see some nice pictures of it. Large mitral valve mass. Let's go look at 13-9. Large mass on the valve leaflet. The absence of clinical signs of infections suggests an alternative diagnosis. If they do not have blood infection or blood test results showing infection, then it's typically not a vegetation. This mass was a blood cyst. Heart disease both obscures the presence of a vegetation and increases the likelihood of false positive findings through misinterpretations. Let's look at figure 13-10. This prolapsing scallop that you see over here on the right-hand side could easily be mistaken for a vegetation. It's not. It's because of severe prolapse and severe MR. But your job as an echocardiographer is to bring out the possible finding, possible vegetation seen on mitral valve leaflet. The doctor is the one that makes the final diagnosis. Of course, in this case, they did order a TEE apparently, and they were able to determine it was not a vegetation. Active vegetations must be differentiated from old or healed vegetations. A reduction in the size might suggest embolization. A piece of it may have broken off, which of course can cause a stroke. Diagnostic accuracy of echo. The sensitivity of chest echo to detect vegetation is approximately 60 to 70%. TEEs are consistently higher than that than chest echo. Improved image quality, the closer proximity between transducer and valves is Y. Smaller vegetations, those associated with prosthetic valves, those in locations that would be shadowed or obscured during chest echo, are areas in which the TEE approach is superior. An additional advantage of TEE lies in its ability to identify other manifestations of endocarditis, such as ring abscesses and fistula. Let's look at 13-12. A fistula between the left ventricular outflow tract and the right ventricle. So it's an opening, a hole between the left outflow tract going into the aorta and the right ventricle. Because of an aortic ring abscess. These are just some of the things that you may run across. Your job as a beginning echo tech is going to be to interrogate the heart in all the standardized views. With color, you would see this strange jet squirting into the right ventricle. Take the pictures of it, leave it to the doctor to make the diagnosis of what it is. In 1994, the Duke endocarditis criteria for the diagnosis was set up. Here's your criteria. Be aware of this. Just go through it. I'm not specifically going to cover everything. But if it's got one major and one minor, or findings consistent with infective endocarditis, but neither definite nor rejected. So you've got to have a major and a minor to diagnose endocarditis. Complications of endocarditis. Variety of complications occur in the setting of active endocarditis, table 13-7. Let's go to 13-7, take a look at it real quickly. Your structural complications, leaflet rupture, flail leaflet, leaflet perforation, abscesses, aneurysms, fistulas, prosthetic valve dehiscence, where the valve actually comes loose from the sewing ring, embolization, pericardial effusion. Hemodynamic complications is valvular regurgitation, obstruction, heart failure, intercardiac shunt, tamponade, and perivalvular regurgitation. So be aware of some of these findings. These are the actual complications if endocarditis is left untreated. Infection of the valve equals tissue destruction or perforation resulting in acute severe regurgitation. Figure 13-13. You see the vegetation, you see the severe regurgitation in both valves in this case. Mitral on the left, aortic valve regurgitation on the right. You've got a vegetation that basically is affecting both of the valve surfaces in this particular case. In the setting of active endocarditis, such changes in valve function often occur suddenly and lead to dramatic changes in clinical status, just sudden blowing regurgitation. An abscess is a local pocket of infection caused by staphylococci or intercocculi bacteria that appears on ultrasound as either an echo-dense or echo-lucent mass within the tissue. Most common location is near the annulus of the aortic or the mitral valve, will affect or can affect the valve function and or conducting system of the heart. Let's look at figure 13-15. This is an aortic ring abscess from a transchest echo, thickening in the posterior portion of the annulus adjacent to the left atrium. This part down here. This is the actual abscess. May extend locally to affect adjacent structures. You saw that where it was affecting the mitral and the aortic. May rupture to allow communications with one of the other cardiac chambers. Echocardiographically detected as a fistula between two chambers of the heart. When rupture occurs, note color flow imaging may just demonstrate flow within the abscess cavity. Let's go look at 13-17. You see the abscess here? Here's your color flow. That's from aortic valve endocarditis. He demonstrated a ruptured sinus of Valsalva. Doppler is essential to document flow within the fistula and to demonstrate its connection to another chamber. TEE is an excellent technique to use. A mycotic aneurysm is defined as an echolucent outpouching of the vessel wall or in the coronary sinuses, either filled with infectious material or containing free-flowing blood. Aneurysms may rupture to produce an intracardiac shunt or undermine the function of the aortic valve. Let's look at 1319. This patient underwent aortic valve replacement 1 month previously. Valve became infected, which led to the development of a mycotic aneurysm at the arrows. Color Doppler imaging demonstrates a fistulous connection between the aneurysm and the right ventricle. Complications such as abscesses or aneurysm formation may result in spread of infection into the pericardial space, producing purulent pericarditis. Most devastating of complications of endocarditis is an embolic event, causing a stroke. Vegetations on the left side of the heart can embolize to cause stroke, distal infection, or ischemia. A highly mobile but small aortic valve vegetation was visualized in a patient who presented with a stroke. Part of it may have broken off and embolized. After such an event, echocardiography will sometimes show a reduction in size or the change in appearance of the vegetation. The appearance of a vegetation may change as a result of embolization. A large and mobile vegetation in number A can be seen attached to the left atrial side of the posterior leaflet. An echocardiogram recorded 1 week later after a stroke, the vegetation is much smaller, most likely the result of an embolization. That does us for this week. As always, please check Google, and you can find things concerning, for example, Lamb's excrescence. You can find things concerning the infective endocarditis. Please look for video images. Any of them that you don't totally understand, send a copy to John at Academy of Ultrasound, or a link at john@academyofultrasound.com. I'll be happy to try to help you interpret them. Continue studying, and I look forward to seeing you in our next lecture. Good night.